HRP2 gene deletions surveillance, and also updates on the recently completed surveys. So it's a pleasure to welcome you to our first forum, and hope you will enjoy the presentations from our speakers. So we can introduce ourselves. As I said, Deusi Shengoma from the National Institute for Medical Research and the Akala Health Institute in Tanzania. I'm chairing the community of practice together with my colleagues Nana, Elisa, and Sonia, and also the core team, members of the core teams who are also supporting us, and we'll have more information about the community of practice as we go ahead. And I hope most of you are members, and in case you are not, please take time and register to become a member of the community of practice. I think we'll get started. We'll have a panel of speakers, Jane from WHO, Regina and Hosea from Kenya, and Matthew, who will talk about different topics, mainly on HRP2 surveillance protocol and experience from the fields. And then we'll have Q&A at the end of the presentations. So please make sure you send your questions, and we'll have more guidance as we go ahead.
First of all, before inviting Jane, our first speaker, I'd like to say that Jane, together with Deus as well and other core members, but Jane is a key driving force behind the MESA community of practice, and to management, and particularly her passion match has been very essential. Jane, as most of you would know, if or not all of you, is a senior technical officer in the Diagnosis, Treatment and Drug Resistance Unit of WHO GMP, and she leads areas of work relating to malaria diagnosis, including the development of guidance, policies and strategies for testing to support case management, elimination, surveillance, procurement of diagnostics, and also quality of assurance. There's a lot more as well, but just to keep it short, I'd like to invite Jane, who will give us an overview of the response plan and the master protocol for surveillance of HRP2 gene deletions, and she'll highlight the relevant modifications that were made in the revised edition of these documents. Thank you very much. Over to you, Jane.
Okay. Thanks very much, and thanks for MESA Community Practice for inviting me to make this presentation today, and also to all of you for joining. I'm pleased to see lots of names I don't know and some that I do. So great that this community is allowing us to, or this mechanism is allowing us to reach more people. So I'm just going to start my timer here, and I will share my screen. Didn't go into practice this before. That's interesting. I'm not seeing it go into presentation mode. Do you have it in presentation mode?
Yes, we can see it well.
It's not the right format on my screen, but I think just a second. I'm sorry about this. We tested this before, and I'm just afraid I'm not going to be able to advance the slides unless, wait, okay, I think it's this view I needed. Okay, sorry about that. I had the wrong view on my screen. I think you're all here because you know of the problem of HRP2 deletions. This is not a new problem. This is a problem we've been addressing since around 2008, when deletions were first described in clinical isolates in Peru, and then subsequently in a kind of smattering of other countries over several years. And then this really blew up in 2017 in Eritrea, where we discovered very high prevalence of HRP2 deletions, leading to high false negative rates. And then this was subsequently confirmed in a number of neighboring countries, particularly in that region. And it was recognized with this problem emerging with a vengeance in Africa, that we needed a coordinated response and guidance on how to accurately report deletions and how to conduct surveillance so that we could better understand the magnitude and the scope of this problem. And we also needed manufacturers to respond through innovation to the needs for better PFLDH performing RDTs, as well as identify alternative biomarkers. And so on the screen, you'll just see some headlines of documents that have been produced over the years. The first one being in 2014, this article in the Malaria Journal, where we outline recommendations around accurate reporting of HRP2 deletions. And much of this content I would still refer you back to this paper. We also issued and have serially updated a information note expanding beyond HRP2 deletions, but also to not forget other potential causes of false negative RDT results. And then in 2020, we released the first version of this response plan. In 2017, we bolted on to the malaria threat maps a mechanism, an interactive web-based mechanism for us to track reports of HRP2/3 deletions around the world. And so this malaria threat maps is still active and still being regularly updated. And a couple of years ago, we also added on to this a survey or a planning tool so that investigators like many of yourselves could provide us with information about planned or ongoing studies or search for HRP2/3 deletions. And at the bottom of the slide, you'll see a link to that, and can welcome you to populate that. And so HRP2 deletions continue to emerge and spread, threatening the lives of malaria patients. As of 2023, and according to the malaria threat maps, parasites with HRP2 deletions have been reported in 41 countries. And in 2023 alone, 4 countries reported HRP2 deletions for the first time, including Burkina Faso, Chad, Togo, and Indonesia. And so this map, excuse me, which is taken from the most recent World Malaria Report, just gives you a sense for the magnitude of HRP2 deletions around the globe. You can see sort of hot spots in the Horn of Africa as well as in South America. But coding here in this slide is not necessarily nationally representative, but it's based on some surveys that have been done in those countries. And so the response plan is grounded around a set of actions. The first one being mapping the distribution and frequency of HRP2 deletion mutants with harmonized protocols. And I'll spend some time on that during the second part of this presentation. Also, ensuring good guidance around careful selection and procurement of new RDTs when a change in testing is warranted, and providing good guidance around when that change is warranted. Very importantly, strengthening an international network of laboratories to perform the complex molecular confirmation that's required in order to accurately map these deletions, and also to contribute to identify new or more efficient methods for identifying and encouraging and facilitating research and development of diagnostics. And then lastly, really taking a look into the future and developing models for planning how we anticipate this problem to emerge in the future, where it will emerge, and how that will impact markets for RDTs in the future. So you all know that to inform your procurement choices, WHO recommends that you use pre-qualified RDTs. But as you know, these RDTs rely on HRP2 detection. And because we still, unfortunately, do not have pre-qualified RDTs that meet our performance requirements for detection of falciparum based on PFLDH. We are still reliant on RDTs that are not yet pre-qualified. And so, fortunately, there are, and these are the products in green here, there are 3 products that, based on independent lab assessment by WHO, do meet our performance requirements, but they have not yet been pre-qualified. They do, however, have ERPD approval, and this manufacturer was recently re-inspected in January of 2025, and we're eagerly awaiting a decision from pre-qualification as to whether or not these products will be pre-qualified. And so they have one that is a PFLDH only test line, and one with HRP2, and one that has a PFLDH test line and a PVLDH test line. There were 2 other products that, based on product testing performance requirements, but these products are no longer pre-qualified. They no longer have any malaria pre-qualified tests on the list, nor are these products in the pipeline. And so I refer you really to these products here in green, should a change in test be warranted in the country where you're working. I'm also going to mention that for surveillance purposes, some countries have also used a couple of other tests that have PFLDH test lines on them. I think one of these tests may have been used in the Kenya survey. We know that these products at higher parasitemia, the PFLDH test lines perform well, but at the lower levels of parasitemia, they will most likely miss these infections. So for surveillance, they may be acceptable to use, but for case management purposes, we don't currently recommend them. But hopefully in the future, we are going to have new RDTs that will meet our performance requirements, the PFLDH analyte, as well as the HRP2 analyte. And this slide just sort of shows you kind of where we've been in terms of the status quo, but where we're going in the near future. And so some of these RDTs are like the ones I just mentioned, where they have just a PFLDH test line alone, separate lines for PFLDH and HRP2, or the most recent kid on the block is where we have combined HRP2 PFLDH test lines. And these products are expected, hopefully, to have ERPD approval, I'm going to say perhaps in Q2 or Q3 of this year. And some of these products, which I'll just quickly flash past on the next slide, have also been submitted for WHO pre-qualification. However, due to the recent actions in the U.S. government, these products are not undergoing evaluation at U.S. CDC because they're frozen in place at the moment. But PQ colleagues are working hard to identify workarounds so that the PQ process can proceed for these products. So before January, I was hopeful that these products may even be pre-qualified by the end of this year. But I'm hesitant to say that at this point, but hopefully they will be at least ERPD approved. Threshold that we recommend for making decisions about changing to alternative RDTs. And this is when the prevalence of symptomatic patients carrying HRP2 deleted parasites causing false negative HRP2 results is greater than equal to 5%. And so why do we have this threshold, and what's the basis for it? Well, the threshold was selected because it's believed that it's somewhere around this point that the proportion of cases missed by HRP2 RDTs due to the non-HRP2 expression may be greater than the proportion of cases that will be missed by less sensitive PLDH-based products. And how did we come to this conclusion that LDH products are less sensitive than HRP2 ones? Excuse me. And that's essentially based on systematic review of performance in the field of these products across a range of geographical settings. And we reviewed in 2022 24 studies looking at the difference in sensitivity, and specificity in HRP2 based RDTs versus PFLDH based RDTs. And suffice to say that what we find is that the difference on average is around 5%. So this review was conducted in late 2022, and this is the reason for why we upheld this recommendation for only making a change when the proportion of deleted parasites causing false negative RDTs is over 5%. Now, this may change in the future as these new generation RDTs and as the evidence is available showing that perhaps these tests perform comparably well to HRP2, and certainly those that include both HRP2 and PFLDH, we may be in the near future seeing a different set of trade-offs. And so this just showing, this is the explanation for the kind of balancing of trade-offs that we've been facing up until 2025 that's really driven the basis for our guidance for change around this threshold. But in the future, we don't anticipate there will be a trade-off in terms of performance. So you're going to keep the benefit of high sensitive HRP2 and more sensitive, and gain the more sensitive PFLDH test lines. Okay, and then moving on to the importance of the strong reference laboratory network to support high quality and timely molecular analysis to confirm or to exclude the risk of HRP2/3 deletions. Countries, including the ones you're going to hear today, just listing a number of the countries there. We have worked through tripartite agreements, so between WHO, the Ministries of Health, and the reference laboratories themselves. And really with the goal to sharing data that can be used for policy making well before publication, so that we're not waiting 2, 3, 4 years for this data to become available, but that it can be, through collaboration, put into the hands of the country programs as soon as possible to inform change. And I think we've succeeded with that. And also to mention that through this network, and Deus is a prime example of this, is we've been expanding this surveillance to also look for markers of drug resistance. And so these activities in this reference laboratory network has expanded and responded to the emergence also of drug resistance. And this is just a link to a recent paper that we published showing the co-concurrence of HRP2 deletions and the 622I K13 mutation in Eritrea. So in terms of the importance, obviously, not only of this network, and I strongly encourage any of you who are interested in joining this network or from profiting from this network, that we are expanding and evolving with this network to meet new needs, and that's forthcoming in this year. Then in terms of the methods, I wanted to point to a publication from 2022. This was released where we present an overview of the different strategies and lab assays to support HRP2 deletion surveillance. And that's because we often get asked, and I think many of you may have the question, is what method should we be using? What protocol should we be using? And we've kind of taken an approach where we are open to different approaches, recognizing that not everyone necessarily needs to use the exact same method, that what's really important is that you're getting the correct answer. And so we can go into this in a bit more detail, but we're just sort of highlighting the advantages and disadvantages really of conventional PCR versus multiplex real-time PCR versus digital PCR, and even sequencing approaches. And I think the MESA platform is and will continue to be an important resource where labs are willing to share protocols and experiences. sorry, I'm not sure I'm going to get through this. In the document, there is also a section on how we're using modeling to predict the future of HRP23 deletions, and what in detail looking at what are the drivers of selection. And there is a application, and the link is here at the bottom of the page. It's also on the MESA web platform, where you can go in and change some of these parameters and generate maps that will illustrate the areas of risk. And so this builds off of a model developed by Oliver Watson at Imperial College. This is the preprint that gives you all the background information about the model. And these are a number of the drivers that we have tried to quantify based on each country to give us the best estimates of risk over time in these countries. And I don't have time to go into this in detail, but I encourage you to use the app and to play with some of these parameters to see what's driving the risk of deletions emerging and spreading and which areas are at most risk. Then we superimposed on that model the current and the anticipated demand for RDTs, and how that demand would shift towards non-exclusive HRP2 based RDTs over time. And you can see we anticipate over the next coming years that up to around half of the demand for RDTs will be for these alternative or next generation RDTs. So this is intended to be a wake-up call for manufacturers and for procurers that if they want to stay in this business, we need to innovate, and we need to also consider how we're going to manage the trade-offs that I was mentioning to you in terms of what we anticipate to be at least a slightly increased price per RDT for these products. So next, I'm going to talk a bit about important changes in the protocols. So we have a master protocol and a surveillance template protocol. The only difference between these protocols is that the master protocol also includes a section on biobanking. So if the materials that are collected during the surveillance are going to be kept and used for future research, there's a requirement, of course, for consent for the long-term storage of those materials. And that's the only difference between these two protocols. So hopefully most of you are familiar with the core approach here for most efficiently detecting HRP23 deletions. This is where there's screening of all suspected malaria cases by 2 RDTs, the HRP2 or the programmatic RDT, and a PFLDH or the survey RDT, or HRP2 based RDT and microscopy. All patients have 2 blood spots collected. And then we look for those patients and those samples that were HRP2 negative and PFLDH positive or microscopy positive. And the resources are targeted at trying to identify if these samples, which are at most suspicious for HRP2 deletions, we actually find deletions here. And we encourage that also a subset of negative samples as well as HRP2 positive samples are also screened for deletions. So what are the revisions? So there's not too many, but one of them is that we, in order to make this estimate of the proportion of PF cases with false negative RDT results due to HRP2 deletions, we've revised the denominator that the number of confirmed PF cases be based on either the PFLDH positive RDT result or microscopy. And this was because basing it on HRP2 or PFLDH or microscopy, the HRP2 results were leading to where we had HRP2 persistence, or they were detecting very low parasitemia samples, which weren't of the primary interest. So we thought we could perhaps refine things by relying more on the PFLDH RDT result. Now, We also included a section that allows for use of lab-based immunoassays, ELISA or chemoluminescent assays or multiplex bead assays like Luminex that some of you may be familiar with, and using this as the approach from DBS to screen these antigens and to look for discordance based on the results of this lab-based immunoassay. And this is instead of using the 2 RDTs or the RDT and microscopy approach. And so this has some advantages in terms of being high throughput and not dependent on field workers accurately recording results. But of course, you can imagine that it cannot distinguish between the presence of HRP2 and HRP3. And there are both commercial and non-commercial options, but the US CDC was supporting a number of surveys with their own made beads. And I think currently there are some issues around being able to acquire those reagents. We also expanded the protocol, as I mentioned on a previous slide, to include a range of molecular methods and not just the conventional PCR method, which was highlighted in the original version of the protocol. And we're also encouraging participation in our EQA scheme to be sure that even if you're not all using the same method, if we have some way for controlling for quality, that's what we want to encourage. And I know I'm going to run over time here, but I want to go over some of the changes in the sampling approach. So in the original protocol, we had, based on the true prevalence of HRP2 deletions being between 3 and 8%, 10 health facilities per domain, the recommendations were to enroll 37 patients per health facility, so 370 per domain in order to reach a power of 80%. And a two-tailed test was applied to detect the prevalence above or below this threshold of 5%. Now, what we identified was an error in how this sampling was originally done. It wasn't us that identified it. It was Bob Verity at Imperial College who identified it and brought it to our attention. And so we needed to correct because the design effect wasn't included. And this significantly impacted and increased the required sample size. But Bob also spent a fair amount of additional time thinking about this and helped us come up with a new sampling approach. And this sampling approach, which is featured in the new version of the protocol, uses a Bayesian statistical approach, allowing for correlations within clusters, allows for higher power, allows for integration of information from other HRP2/3 deletion studies, uses a one-tailed test to identify areas that are above the 5% threshold instead of focusing on also being below the threshold. The number of clusters, or this means health facilities, can be selected based on the practicalities of the study location. And you can also choose a higher number of clusters, and that will allow for a lower number of overall sample size per site. So the sample size, fortunately, based on some default settings, has not changed significantly from the original protocol. So that's a relief. So it's now 30 instead of 37. And what's important is that you need to consider, there's been an application that's been developed, and the link to that is here at the bottom of the slide. And so I encourage you to go to this and to play around with it. We don't have enough time to do a demo. I know that Bob has been involved in different presentations, webinars, seminars, and has done some demos on this. This is also a link to a recording in which a demo was done. So if you'd like access to that, let me know. The link may not work directly for you, but just to say this needs to be done for each domain that you select. And so just a few highlights before I conclude with this planner is that the app is very flexible. So you can use the default settings or you can customize based on what you know about your site characteristics. It will automatically calculate the power based on changes in sample size or the number of clusters. So if you thought you were going to have 10 sites, but now you only have 8, It will automatically tell you how that changes your power. You can then change the sample size. It will generate a new power and tell you whether or not you've got the 80% power that you're after using those numbers. It also allows to account for dropout rates. And if during the study you've had sites that you can no longer enroll because of security issues, for example, then you can generate the new sample sizes that you need from the remaining health facilities. So if you use the old protocol with different sample sizes, you have most likely collected a sufficient number of samples to make your powered conclusions. But you can also go and enter the data based on what you did collect and find out. And just in terms of selecting domains, I will say that what's really most important is that you select domains that span all the transmission zones in the country, because we know that the HRP2 deletions are most likely to emerge in low transmission areas, but these are the places where it also takes the most time and energy to collect patients, because that's where you have fewer patients. And there is also an opportunity for a more advanced analysis. If you're interested for further understanding, you can go to this link where the whole kind of background of this DR Power application is explained. And there's also a really brilliant frequently asked questions section that I encourage all of you to go to and read. And it's a really quite powerful, nice tool. And fortunately for any of you that have surveys that are ongoing or have got data that you collected from the old protocol, we don't anticipate there's going to be any major impacts for your results. So I'm sorry I've gone over time. I'm going to stop there. Thanks very much.
Thank you, Jane. Thank you so much for a great presentation. And I hope everyone appreciates how this now updates our understanding and approach to HRP2 gene deletion surveillance. Our next presenter will be Regina Kandie. Regina is a medical laboratory scientist with an MSc in tropical infectious diseases from the University of Nairobi. She's the head of diagnostic and private sector engagement at Kenya National Malaria Program, overseeing diagnostics and case management activities. She's an experienced colleague from NMCP, and she's among the few colleagues from NMCP who are very active. And thank you so much, Regina. She'll be presenting together with her colleague, Hosea. Dr. Hosea Akala is a parasitologist with a background in medicinal chemistry and serves as the principal research scientist at the Center for Clinical Research, Kenya Medical Research Institute, and Walter Reed Army Institute of Research Africa, Kandie, Walter Reed Africa. He is the director of the Malaria Drug and Diagnostic Resistance Program at Kandie and Walter Reed Africa. Hosea oversees the Kenya Ministry of Health HRP2 and 3 gene deletion surveys supported by WHO and Global Fund, and collaborates as a co-investigator in various international and local research initiatives. The title presentation by Regina will be Findings and Lessons Learned from the Country Surveys in Kenya. So over to you, Regina, and we will be happy to hear from you.
Thank you very much for the introduction. I'll be presenting on the Kenya surveillance of HRP2 3 gene deletion for Kenya. This is the outline format for my presentation. And I just want to highlight in this slide that RDT are the preferred and most deployable support tests for case management of malaria. And we know that RDTs are used, and within our neighboring countries, we have had reports of declining efficacy of rapid kits, and some of them have changed in terms of the rapid kits they use. But for Kenya, we did not have a report on the prevalence of the HRP2 3 deletion. We had 4 objectives during our study that was conducted in 2022, looking at the prevalence, the parasite density, predictive value that is positive and negative, and also we were looking at the various regions that would inform subnational change following the findings. In terms of methods, we looked at suspected malaria cases in representing all the epidemiological zones in the country, and the points that are marked green points are the regions where the study was conducted, and we followed the previous WHO protocol as was guided. In this presentation, we had the participants per age representing, where age less than 5 years was the highest. And then we had those participants also clustered in terms of gender, that is having the females with 57% and each categorized per county. So a total of over 5,000 samples or patients were sampled during the study. We had the suspected, during the study, discordant results were also analyzed per county and is represented, whereby the discordant samples were 1%, that is about 65 out of the over 5,000 samples that were presented. Looking at gene deletion after the molecular analysis that was conducted, we find that we had a prevalence for the HRP2 deletion being 0. However, we had 5% of single deletion of HRP3 from our samples. Of note also, 45% of the samples, of the discordant samples, were non-falciparum, meaning they contributed to the deletion, and we had Plasmodium ovale noted, and also Plasmodium malariae, and mixed infections of the same that was reported. From this, what is the policy implication for Kenya? It means that this prevalence is categorized under the below 5% category, meaning our test kits are still accurate and we need to, we can continue using them in the symptomatic infections. However, we need to continue monitoring. Of note also is that we need to continue doing this study every 2 years per the results based on the WHO protocol. And also that non-falciparum parastemia contribute to the false HRP2/3 deletion results that was noted from the study. During the study, we had the following challenges: funding constraints. We also had a delay in molecular analysis. We did this study in 2022, and this is the time we're having our final data. Seasonal data collection, there was variation in some of the samples. Extended sample period because of the long time for collection of sample contamination. We had invalid results that could be part of this, and also logistical challenges in terms of transportation, especially in remote areas. The key lessons that we learned from our study is the need for us to have proper sample and storage collection methods improved. We need to ensure that there is consistent funding before commencing the study. We need to strengthen microscopy as one of the methods, as it is our gold standard, and also enhance laboratory diagnostic quality and quality assurance, and continuous monitoring following the report that we are below the recommended threshold for change. Therefore, we continue monitoring. I think I also want to acknowledge the following contributors for the great work that they contributed to Kenya having the final report. Thank you. Over to you.
Thank you so much, Regina. Once again, a great example of a colleague from NMCP who is on the lead, actively doing what they are supposed to be doing. You are such a star, and I hope colleagues from other programs will learn from you and take an active role in this kind of surveillance. Our final speaker today will be Matthew Coldiron. Matthew is a physician and epidemiologist who has worked with the MSF the International Medical Humanitarian Organization since 2011. After completing an AB at Princeton, he received an MD and MPH degree from Emory University and completed residence training in internal medicine at New York University Hospital in New York. He's board certified by American Board of Internal Medicine. He has worked extensively in humanitarian contexts in sub-Saharan Africa, providing medical care and designing and leading observational studies and clinical trials. His areas of expertise include meningococcal meningitis, malaria in the Sahel, the treatment of snake bite. That's amazing in resource-limited settings and emerging infections. He's currently the director of Manson Unit in London, which provides medical research and innovation, clinical support, epidemiology, social science, and e-health services in MSF program setting, and is Deputy Medical Director of MSF's Amsterdam Operations Center. Matthew will be talking about the findings and lessons from the country survey in Sudan. Welcome, Matthew, and we are happy to have you on the forum today.
Hi, it's good to be with you. Just a quick check that you see me and hear me and see my slides correctly.
Super. Go ahead, Matthew.
Great. Thanks for that introduction, and thanks for the invitation today. I'll just jump into South Sudan in general, with the first caveat being that, as you know, South Sudan is undergoing a moment of particularly difficult political tension, and my thoughts are with the patients, the participants of this survey, and folks around that country that have had plenty of suffering over the last decades and are having a particularly difficult moment as we speak. But malaria is one of the biggest health problems in South Sudan, almost one case per person per year, but with very different transmission patterns. In the north, it's seasonal, and in the south, it's really holo-endemic. But we also know that it's in sort of a complicated neighborhood with the emergence of HRP2/3 deletions in Ethiopia, Eritrea, just to the east, and the emergence of artemisinin resistance in northern Uganda, just to the south. But because of the remote nature of the country, because of the difficulties, it's difficult to get information. There is a little bit of information that is out there prior to the study that we did. Two small sites, single site studies showed one of them in the north a very low proportion of children with HRP2/3 deletions, one in the south with a higher proportion. Neither of these were designed to look for HRP2/3 deletions. They were sort of convenient sampling of other patients, so it's a little bit difficult to interpret. Likewise, there was a study among returning travelers to Australia where there was a high proportion, but again, it's very, very difficult to interpret what the presence of these deletions among returning travelers means. Given the fact that it's a bit of a black box, that it's in a neighborhood that we're concerned about, and that MSF has a very large operational footprint around the country, we embarked on doing a nationwide survey that was based on the standard protocol that Jane described. In this case, the domain, though, was the country. Very honestly, the getting in and around South Sudan is complicated. Getting from the capital even to these single sites involves often air, helicopter travel. Just doing it using a domain sort of at a state or a county level was just not feasible in this case. But we did choose 10 MSF supported facilities around South Sudan, a variety of inpatient and outpatient facilities. We included children, mostly under 15 years old. In some sites, it was only under 5, who had fever or history of fever, and anyone who had any sign of severity was not included in the study and was referred immediately to a higher level of care. So what we did, and this is again along the lines of what was done in the survey, in the protocol, we did the rapid tests in parallel and took dried blood spots. It was the Rapigen PLDH RDT that was used at all of the sites, and at different sites there were different HRP2 tests used. And then our colleagues in Australia at the WHO Collaborating Center performed the molecular analyses And importantly, they also looked at the K13 mutations among about half of the positives from each site. And then the sample size, going into the different versions of the protocol, I'll tell you what was going through our mind when we set the sample size. We knew that we weren't going to be able to follow real time the number of positives. So we were hoping to have a positivity rate. So we assumed that some samples would be negative. So we set a sample of actually 200 per site, which again, with retrospect was overkill. We also assumed that of our 10 selected sites that we wouldn't actually be able to complete data collection at all of them, because it's South Sudan, because it's a complicated place to work, because security is complicated. So by sort of going a little bit larger than we needed, we gave ourselves a little bit of buffer in case some of the sites weren't able to complete enrollment. So here are the main findings. The survey was completed between January and March 2024, so a little over a year ago now. We included almost 2,000 participants across the country with a median age of 3, about 10% of whom had reported malaria treatment in the 2 weeks prior to enrollment. Just 2 things to note: South Sudan also neighbors Sudan. A couple of the sites are in the north of the country, and the survey was going on around the time of large displacements because of the Sudanese civil war. In almost all of the sites, almost all of the participants are from South Sudan. At one of the sites that I'll show, Malakal site, about 40% of the patients had arrived into the country within the previous month, and those were exclusively folks coming from Sudan. In terms of the RDT positivities, this is again by site. The overall positivity was 40% for HRP2 tests and 32% for PLDH tests, and a total. So that there were of the 584 total PLDH positives, there were only 14 HRP2 negatives. So that's on RDTs alone about 2.6% of suspected cases of deletions, or at least of discordant positive results. When you looked at those molecularly, though, of the 14 discordant samples, 4 were negative by PCR, 3 were positive for falciparum, 2 of which had double deletions, and then 7 were positive for non-falciparum species, 4 for ovale and 3 for malariae. Therefore, when you take all of that together, there were 2 double deletions that led to a false negative RDT, false negative HRP2 across the 2,000 samples that we collected across the country. That's 0.35% with fairly tight confidence intervals, and none of the individual sites approached that 5% threshold. There was one double negative that, the 2 double negatives came from 2 different sites. It's not that there was one site that had multiple. So in the end, to summarize, reassuring. In terms of the K13 mutations, just to throw it out there because I think this is also interesting to people in the neighborhood, the proportions were actually low among positives, under 1% in both, with no real clustering. One of the mutations was more in the south of the country, near the border with northern Uganda, and it was the same mutation that's been reported in northern Uganda. And then another one in the north of the country. So in the end, big picture, we were reassured about the proportion of HRP23 deletions not coming anywhere near the threshold to switch to the LDH RDT across the country. Nonetheless, I would say that this is much broader than sort of what's intended in the protocol, right? The domain was the entire country. It wasn't a state. It wasn't a county. So I think continued follow-up would be needed, but in the immediate term, it at least provides some reassurance that in this complicated place where access is very difficult, we're still reassured. And then the question, and I think Jane's sort of introducing this already, but about which PLH test we should use in future activities is a very pertinent one, especially given some of the discordant ones that we saw were actually due to non-falciparum species coming up as positive. In terms of the challenges and lessons learned from this study, this was a huge partnership, and it took us a while, to be really honest, between WHO, MSF, the Ministry of Health of South Sudan, also our friends in Australia. It's just a lot of people around the table, and we got there, but it was a bit of a slog, and I think there's always lessons to be learned there. I think ensuring good supervision in remote and difficult to access areas is complicated. MSF put a lot of time and a lot of effort into supervising in the field, with multiple people flying around the country doing this. It was a big ask. We did have some implementation delays, so we missed the seasonal peaks, and some of the sites were under enrolled in terms of what their targets was, and didn't quite get to the number of positives you would have liked to have seen. But again, given the size of the country and the machinery necessary, the logistical machinery necessary, we didn't really have any other choices. And then in terms of the operational compromises we made, again, because we didn't have real-time monitoring of positivity, we just we had 2,000 PLDH tests, and we knew that's all we had. We just did the best we can by dispatching 200 per site, and that was a choice. But I will say the good thing that we did, or at least I think the good thing, is that we used this opportunity, again, figuring that it's one of the few chances that we'll have to do this scale of monitoring in this country, to look at the K13 mutations as well. So again, a huge thank you, particularly to Chin and her team in Brisbane, my colleagues at MSF, the whole team at the NMCP in Juba, who some of whom have changed now, and also especially Jane at WHO for really pushing this forward and keeping hope alive even when it got complicated. Thank you very much.
Thank you so much, Matthew. This is very, very nice. So we are grateful to you and other presenters, and you agree with me that they have been brilliant presentations. We'll now move to Q&A, and my colleague and I, Nana and I will be moderating the Q&A. And we have questions which were put forward before this forum. So Nana and I will try as much as possible to get the questions to the presenters so that we can have some responses. And we also have been compiling questions which have been coming in, and some have been answered. So we'll see which questions are really important, and we can bring them up. So Nana, we have two parts of the questions about the protocol and the questions about experience. So I'll let you take questions about the protocol, and you'll be asking one question, and then I'll do the next. So you can start with the first question, and after it's answered, then I can do another question on the country experience. Over to you, Nana, and welcome to the presenters, and I hope you are ready to respond to the questions.
Fantastic, Nils. So some questions have come through, and Jane and has been answering some of them as well. So I'll go with the first one that came through during the registration period. That's from Eritrea, Salam. What sample size do we take when we do follow-up pfRP2 gene deletion surveys in countries where the situation is previously known? Jane, that goes to you. So study design.
Well, actually, if Bob Verity's still on the question, I might punt it to him. We haven't developed, actually, Salam specific guidance on this, actually. So it's a good question. I'm not sure. I mean, what you would be able to do is use some of the data that you'd previously collected to refine your sample size. So I think you still want to have the same power, and you may be able to limit the number of domains perhaps that you want to target, but things like this intercluster correlation, so how much difference is there in the prevalence of HRP2 deletion between health facilities? Well, you actually have data to give us an estimate of what that intercluster correlation is. And that would allow you in this application to refine your sample sizes. But I'm not sure that there's anything specific about it being follow-up that changes the sample size. But if Bob doesn't mind taking the mic, I'll let him answer, because he can give the proper statistical response.
Yeah, thanks very much, Jane. What you gave was, I think, the exactly correct statistical response. What I'm going to say is basically the same thing. In the current version of the method, there's essentially a prior. So just our beliefs before we've seen any data on both the prevalence of deletions and on the intracluster correlation. Now, the method assumes that we know nothing about the prevalence of deletions. It's completely flat as you currently use it. And for the intracluster correlation, it assumes a distribution just from historical studies. But if you've already conducted something in your country, then you could take the results from that first analysis, and it should give you a narrower range in terms of what you think is a plausible prevalence of deletions, and also some information about the intracluster correlation. So you can just feed those two distributions into the same method. It's kind of like you're just you're learning from the previous analysis, and you're bringing that into the second analysis that you're doing. There should be some guidance on the app or on the associated tool as to exactly how to do that. But it's just a case of changing a couple of parameters of the method to change that prior distribution. But yeah, I agree with Jane that now that we have more surveys going on, more kind of longitudinal things, these kind of more advanced sampling schemes could be built into future kind of versions of different apps.
Thank you very much, Bob. Jane, did you want to say anything else? Otherwise, I was thinking, Salam, are you on the line? If in case you want to chip in as well. Any other question? We'll continue, and if you're there, Salam, just drop a note in the chat. Davis, over to you.
Thank you so much, Jen and Bob. This is exciting. So I'll now move to the country surveys. I have a question from Alpha Jaro from Sigas, Senegal. And Alpha wants to hear from you guys, what are the main challenges both in sampling and genotyping? And I think you mentioned about these challenges, but since you're here, I think it will be great to hear from you briefly what were the main challenges and how you faced them with sampling and genotyping. So we'll start with you, Regina.
Thank you very much. So the main challenge with the analysis, I'll begin with the sampling, is the long period of sampling because we needed to reach that exact sample size. So we took a long period, meaning storage within the facilities took also longer, and therefore affected also maybe the integrity of the samples in the field. The other challenge is in terms of analysis. We had to ship these samples to the Australian laboratory to be able to analyze for us. This also took some period, and we just received the results about a month ago. So how we are working towards that is to ensure that we follow the new protocol. Because we use the old protocol, we'll follow the new protocol and be able to do proper training on the sample collection and also on storage, and to be able to reduce some of the errors that we saw. We hope that we'll be able to do periodic monitoring during the studies. Thank you.
Thank you, Regina. Matt, what are the responses from your side?
Sure. And I apologize. It looks like my camera is not working, but I apologize.
No problems. We can hear you loud and clear.
I mean, I think I sort of spoke to the difficulties of South Sudan. That I think if you've ever been there, you know it's a complicated place to get people and things to. In our situation, we had a really nice collaboration with the NMCP, also understanding that neither the NMCP centrally nor some of the peripheral level MOH folks had the capacity to help us, and this is a situation where they're overwhelmed with everything else. So MSF was able to provide some of the human resources and the logistical support to be able to quickly go in, do the data collection, the sample collection, and then facilitate the transfer out. I think that doing this outside without a partner with some logistical capacity would have been very, very challenging for the ministry. And I think that was, for us, it was a good partnership in that sense, that we sort of had a common goal and we worked together to get it done. And then, yeah, likewise, I think, yeah, that to me is the biggest challenge. But we were, since we had a goal, we put the resources that we had behind it, and it was possible. But I think this sort of thing is challenging in a complicated environment without some external resources.
Thank you, Matt. If I can ask you a follow-up question, did you find any co-occurrence of HRP2 gene deletion and drug resistance in the few samples you detected?
No.
Okay, great. So back to you, Nana, for the second question.
Yeah, there's a question that has come through, actually went to Matthew, and Matthew was suggesting if, Chen, I don't know if Chen, if you're online and you can be able to take the question. Matthew, congratulated for your presentation, like all the others. And it says in your molecular analysis, did you observe any samples with partial deletions? I don't know, Chen, are you there? If you can drop a note and then perhaps you can take that question.
Yeah, thanks for the question. We used the multiplex qPCR to detect HRP2 and 3 deletion. So the method really just examined exon 2 of both HRP2 and 3. So in a way, we didn't look at the partial deletion of exon 1. So exon 2, we only look at exon 2.
Thank you very much, Ian. David, over to you then.
We have a hand by Jane.
I just was wondering if Chin could further elaborate, because it relates to a question that's here in the chat. I just wondered, Chin, if you, in the South Sudan samples, if you tested a subset of the HRP2 positive and or HRP2 negatives and looked for mixed infections amongst those samples to see if there were any suspected HRP2 negative and HRP2 positive samples.
Mm-hmm.
Yes, so we basically analyzed all discordant samples that are HRP2 negative, PLDH positive, and all positives. So plus 20% of all negatives. We used a cutoff of, we only classified a sample that have a gene deletion when 90% of the parasites had were deleted in that sample. So if it was in a way, we only classified a deleted sample when the deleted parasites are predominant, very dominant in the sample. So there are some samples that, give a CT value shift of 2 cycles or between. We haven't really. I think they are suspected of mixed infections of deleted and non-deleted parasites. However, the assay itself also has variability, when you repeat the assay. So we can't 100% to say they are mixed infections. It could be mixed infections or could be the assay variation. So that's why we set the bar really high. Only if the deleted parasites is greater than 90% in the sample, then we call it deletion. And this is also, I guess this is also the sample that will have clinical relevance, because it's likely to cause false negative RDT results.
Okay, thank you, Jen and Chin. Back to Regina and Matt. The question is from, is from Numa Pasco Camano from Guinea. who wants to know how did you manage to finance the surveys? We'll start with Matt this time.
Yeah, I can start. So in this case, the assays were financed with the ADF MIDI's core funding, and I will let Chin speak to exactly where that comes from, but as part of their collaboration with WHO and their other financiers. For the operational bits of it, so that's the human resources, the nurses, the supervisors, the flying samples around the country, and the trainings. That was all financed independently by Médecins Sans Frontières, by MSF. So that was, again, that was sort of the dividing and conquering of this, that we provided the labor and the logistics, and WHO via their network was able to help with the financing. But I'll let Jane or Chin speak to the rest.
Jane, do you want to say something?
No, not really much to add.
Okay. Regina or Hosea?
Thank you
How
so
did
much.
you manage to fund the surveys?
Yes.
And the lab work?
Yeah, thank you so much. I'll go for this. So for specifically logistical collection and running of sites, including financing of operations for sample collection, storage, and transportation, we were funded by the majorly by the Global Fund, which also funded a section of supplies required for collection. But again, due to some funding shortfall, we had a chipping from WHO that helped us with some diagnostic kits, as well as the DBSs and a few other supplies. Then further, for molecular work analysis, we leveraged on majorly the support from the ADF, and also the staff at the Ministry of Health facilities were also key in terms of, as part of the inherent contribution from the local malaria, that's National Malaria Control Program. Over from me.
Thank you. I will now hand over to Nana, but before I do that, I would like to assure everyone that all the questions will either be answered now or after the forum. So keep sending your questions, and even questions which were sent before the forum. In case we run out of time, we'll make sure they are answered, and we'll share the responses through our network. So over to you, Nana.
Yep, thank you. I think I'll try to match two questions. Regina, they are going to you, Regina and Hosea. So it says the survey in Kenya, there were a high number of invalid samples, and if you could expand a little bit on how you can minimize this. So I don't know if Regina, you're trying to post that to maybe for Jane. And then there's another question. There's another question that's related as well. That's come in the chat now. That says there were issues with sample storage, and you referred to data integrity as well. If you could elaborate a little bit more on that, Regina, that's for you.
All right, thank you. So the issue of sample integrity, we noted, yes, indeed, the high number of invalid samples. This is mostly due to, there are many reasons. One could be low parasitemia level. Therefore, there was a low DNA concentration. Therefore, it was summed as invalid. So I think that is the main thing. So how do we plan to address this? Proper training during the sample collection. And I think what is important that I had earlier mentioned is the periodic monitoring. And it will be important also for us to have the storage and the turnaround time for the sample collection to be reduced. I don't know whether Dr. Hosea could add something.
I would also just say that based on the malaria burden in the country, we anticipated this because some regions are very low immunity places where we were collecting samples from. So it was likely that we would get people showing up with symptoms at pretty low parasitemia, and then the tests turned out negative just because the patient had already shown up and he was having very low parasitemia. And again, this was because of the stringent threshold for the assay that was set by the ADF. And I think Dr. Ching Cheng is on line. She could elaborate more on that because we understand that there are very stringent guidelines, QC steps that are involved in just confirming that the assay is positive or not because of the implication of a negative HRP2 tests. Probably, Kingshan, if you could add anything.
You're muted, Chen. You're muted, Chen. I'm gonna unmute. I can't need her to unmute.
Maybe Sonia can help to unmute Chen.
Oh, yeah, I got it. Yeah, I couldn't unmute myself because the host muted me. Because the complicate, as Jane mentioned, the the detection assay can be complicated because of low parasitemia. So we've set the cutoff for valid using a multiplex qPCR. So we set if the human tubulin gene is over 30 cycles, the CQ value, then we classify that as not efficient extraction. And if the PLDH CQ value is greater than 35 cycles, then we classified that as invalid because it's too low. It's too low to assess whether the HRP2 and 3 genes were deleted. So we only the classification for invalid samples is they have either low or no parasites in the sample. This is just to make sure the results, the deletion classification is accurate.
Sorry, Chin, did you try to make sure your qPCR is quantitative?
In terms of parasitemia, you mean?
Yes.
No. You could. We have a standard parasite DNA control that we can quantify absolute quantity of parasite DNA. However, because the samples are coming with filter paper blood, dried blood spots, and we can't control the volume of blood on the filter paper, right? So each filter paper spot will have different volume of blood on it. So we cannot, the absolute quantity of DNA doesn't really reflect what the parasitemia in that sample. So we can determine the relative parasite DNA quantity in a sample, but that's not directly correlating with parasitemia. But however, in terms of parasitemia, we would suggest that you only assess samples greater than 100 parasites per microliter. Yeah.
Okay, so Jane, are you suggesting that probably the dried blood spots were not of the highest quality, because we have recently optimized the method of detecting drug resistance mutations in samples which were RDT positive, and we based on the quantification. So all the samples which had sufficiently high, I can't remember the cutoff, sufficiently high quantity of parasites went through sequencing, and we are able to report that. We'll have a poster test MH, but I think this is something we can discuss further in a different session to give room to other questions. So is it,
I think
to me? Oh,
sorry.
Okay, go again, Chim.
Yeah, I think it's the sensitivity of detecting drug-resistant mutations are higher, so you can amplify the drug-resistant genes from very low parasite density samples. With HRP2 and 3 deletion, because we're looking at the CQ value shift between HRP2 and the PLDH, so we need the 3-cycle shift to detect that 3-cycle shift. So you can't really go really low parasitemia.
Okay, I'll do the next question. And this is from Dr. Priya Sharma from India National Institute of Biologicals. I think this will go to Jane. What are the strategies which you might adopt to do a survey in a very big country that I can understand for the question coming from India? So Jane and even Bob, what would be the response in terms of what strategies could be adopted in such a big country?
Yeah, I mean, I think this is a very good question. I mean, yeah, because we say we want to have nationally representative data, but fully recognizing that for a number of different reasons that may not be feasible, but it's also not a reason to not look. And so typically what we've advised country programs in the past is, first of all, if there are places where deletions have already been reported. So there's already been a signal, could be a case report, could be samples from a TES survey, whatever it might be, where there are signals, definitely that's an area where you want to try to learn more to understand the magnitude of the problem. If there are border regions, so, you know, if, for example, you know, when it started in the Horn of Africa, Somalia was looking close to Djibouti, Ethiopia was looking close to Eritrea. So that's where all of this started. So go to the areas where you have signals. That is what I would say would be one of the priorities. And then secondly, I would suggest just including areas, all transmission zones within the country, not just going to the places where it's easiest to collect samples, because we know these parasites are likely to become more dominant in areas where there is lower transmission. And so those may be harder to, they may take longer to recruit patients from those sites, but that would be my other bit of advice, is to look at, okay, these are the resources I have. I'm going to do a survey. I'm going to focus on this hotspot because there's been reports, and I'm going to focus on 3 other locations representing different malaria transmission within the country. And that would be the approach, I think, minimum kind of requirements approach that I would take if you cannot do a more broadly representative surveillance. And over to Bob for his comments to layer on top of that.
Thanks very much. I don't have much to add on top of that. I think one of the tensions that people have when designing these studies is the fact that to get a large number of clusters, you sometimes have to focus down on a smaller number of districts within a country, and that can feel like it leaves some areas unsampled, and that's particularly true in large areas, large countries. Just to emphasize that there's this kind of tension between, on the one hand, nailing down one protocol that is standardized and can be applied everywhere, and that's really what this statistical protocol is about. But there are other designs that you can take that deviate from this protocol that, for example, would have a smaller number of sites, let's say, distributed between more regions. But the problem with those is that then it's its own kind of bespoke analysis. It's not standardized in the kind of WHO way. So just to say that there are other kind of sampling designs that can be taken, but if the focus of this exercise is really to narrow down on one that is statistically robust and reliable and can be applied in lots of different areas, then that's why we have this one that includes multiple clusters in a single region, and that changes the that does have constraints in terms of the number of districts that can be covered.
Thank you, Bob. Over to you, Nana.
Yep, I was just going to follow on that, another question from India, from Dr. Supriya. It's asking about which protocol is best suited for deletion study, one-step multiplex or standard protocol.
I'm wondering, I don't know if Chin, you want to answer based on your experiences, because you've transitioned and tried different approaches. Again, we don't, from WHO's perspective, we're not recommending a specific approach. We're trying to recognize that there are different capacities and experience and resources in settings where this is all relevant. And so it's more to be sure that the method that you are following, you're following to a high standard. But I'm going to maybe let Chin, if her mic is open, respond to that. I think there's good reasons to prefer multiplex real-time PCR, but Chin, go ahead and comment.
Yeah, I think in our experience, the conventional PCR, I guess, is still a gold standard as a control that you can validate the new assays. The multiplex qPCR really speed up the analysis. It's so efficient, and also it saves a lot of DNA samples, blood samples, because it has all the, has human DNA control. There's PLDH control that built in within the assay, so it's very efficient, and it also allows to detect gene-deleted parasites in a mixed infection, which we couldn't do with the conventional PCR. From our experience, in places where you always have mono infections, like in Peru, in Eritrea, and in really low transmission areas, the conventional PCR results matches the qPCR results very well. When it doesn't match, it's really in the high transmission area, where you have multiple clone infections. In those areas, the qPCR can pick up more deleted gene deletions. I think the best benefit, well, the most benefit is really the simplification of the assay, although it costs more, but it's really speed up the analysis.
Thank you, Chin. We are about time, but before we finish, I'll have a quick question to Regina and Matt, and I will request you to answer yes or no briefly. Did you encounter any issue with the staff getting confused with the test interpretation of different RDT types in health facilities included in your surveys? This is from our colleague Elisa in Spain. If you can give us a quick objective answer, yes, no, if possible.
No, it's a no.
No?
It's a no?
Yeah.
No.
Yeah, likewise, it's a
Matt?
no, and it was no, and it was very clear because we were using two separate tests, and it was for direct patient care. The rule was that if you had one positive, no matter which it was, treat. And that's sort of what we said, and that led to no confusion.
Okay, so thank you so much. Before we wrap up, I'll invite my colleague Nana from MESA to give some remarks and thanks to the presenters. Over to you, Nana. Hello, Nana, you are muted. Please unmute yourself.
Yeah, that's fine.
Okay.
Now. Just wanted to say thank you to everyone, especially to the to Jane and the presenters who've helped us in building this up, and just we've all had a chance to listen to the updates, especially the relevant modifications to the protocol and some country experience. Obviously, we need much time to be able to get into deeper extent, but like we said, this is going to be a continuous conversation, and there's a community of practice as well. So we're very happy if you join, and we have a pool of experts as well, including Jane, Chin, Deus, and many other experts from country who are actually performing the surveys. And so we can we can continue with the exchange over there. Before we wrap up, I'd just like to ask Hosea and Regina and Jane and Matthew if you have just a short remark, just a summary for us before we close, very shortly, please.
Well, just to thank everyone again for joining and for MESA for organizing this session. Thanks. My special thanks to Chin and Bob, who I didn't know would be on the call today. So much appreciated their expert views and experience, both in the lab and also with these new tools that we're hoping will serve the country programs in designing and analyzing these studies. So looking forward to your feedback on the presentations that were given today and to keep the dialogue open. So thanks very much.
Jane,
Thank you.
and Hosea and Regina.
So I want to thank everyone for having to listen to the current status of our HRP2 deletion for Kenya, and those who supported us to see that the success of the findings, those who did the molecular analysis, and of course to WHO for the guidance protocol, and even for the upcoming survey that we need to undertake. We request that we be supported again so that we implement it better. So thank you for the collaboration. Over, Hosea, thank you.
Matt?
Nothing other than to say thanks. Thanks for to the organizers, and thanks for your attention.
Yeah, thank you very much. Thank you. I'd like to say thank you to the interpreters as well, who've been simultaneously translating all of this in French. I'm not sure if, Sonia, if you can put a slide up. Most of the resources that Jane particularly presented are in the compilation of resource that MESA has created, and you can access that as well. And again, feel free to contribute to it, especially with your best practices and SOPs, which typically protocols as well, which come in handy for others to be able to use. Sonia, you can move to the next slide so that they can see how the collection is assembled. And then I'd like to say a very big thank you as well to Deus. He's the chair of the community of practice. It's really fantastic working with you, Deus. So I don't have anything else to say, just hand over to you to close the forum.
Thank you all for joining, and it has been a great pleasure to have you on our first forum, and it happens to be my 55th birthday, so thank you so much, and see you next time. Bye.
Bye-bye, everyone. Thank you.
Happy birthday.
Thank you so much.
Bye-bye.
Bye.
I'm gonna try to leave.